I'm Professor Mark Freedman, and I've been asked to debate this topic that MS is a primary progressive disease in all cases, but that some patients have superimposed relapses. And my take on this is incorrect. I have some disclosures, but none of these are really pertinent to today's discussion. I'm going to cover these points in the next few minutes, and these are the main reasons why I feel that this statement is untrue. First of all, not all disease in MS manifests clinically as relapses. We know for a fact that there's actually quite a bit of hidden disease, and this is demonstrated in a few ways. The MRI was most classically able to demonstrate subclinical disease by showing us new lesion formation in people who were completely asymptomatic and absent of any kind of symptoms suggestive of a relapse. More recently, we've been able to use a biomarker such as neurofilament light protein that can be measured in the serum or spinal fluid, indicative of axonal damage that occurs very early in the course of this disease, and usually in the presence of overt inflammation, either seen through the MRI or clinically with relapse as well, but most consistently with pathology. We also know that this disease is a progressive disease that goes over many, many years, and that too doesn't necessarily present itself clinically until a certain threshold of loss of axons is seen. Early on in the disease, the ability to compensate for damage through mechanisms such as plasticity, through redundancy, also dependent on the patient's ability to repair demyelinating areas, and also the luck of the draw, so to speak, as to where lesions tend to occur are more likely to present clinically, such as the optic nerve. It's very hard to prevent someone from not noticing they cannot see. And if someone has a lesion in the spinal cord, it's most likely that they're going to have symptoms because it'll affect their walking or control over their bladder. But there are lots of other places where lesions will occur that they don't manifest clinically. We have also seen that the disease-modifying medications that have evolved over the last probably 15 to 20 years, really, they impact progression only after their effect on relapse. So they've all been licensed to show that they reduce relapses. And if they're able to control the relapse formation, then progression is often slowed or not seen at all. But there is this lag that we see in the tendency of the prevention of relapse to not show up on progression for a little period of time thereafter, and we'll talk about that. And finally, if we can drive away all relapse and inflammation, which we've been able to accomplish with treatments such as a full myeloablative bone marrow transplant, pretty well progression ceases. So let's go through some of these points in particular. I like to think of MS as a continuum, and as you can see, starting at the RIS stage, where people are suspected of having MS by the virtue that they have an MRI that's abnormal, through the presentation of the first clinical attack when they have symptoms, evolving through a period of time during which they relapse and remit, and then transition into a secondary progressive phase. Lots of things, as you can see, are going on here. We have demyelination coming and going, but this pink line here is the clinical threshold, above which patients are aware of symptoms, above which doctors are able to pick up changes due to these demyelinating events, and under which you don't perceive any of this. The green line here is key. The green line here shows that the axons that are really being demyelinated early on start to become deficient, but only after they reach a critical threshold, whatever that happens to be. A patient starts to realize that they've lost all these axons by showing progression. But the progression really starts early on. It's just that's the threshold that is different in everyone. And in some people, the threshold may be over here or over here, but the threshold is defined by each individual. We also know that very early on, if you were to look, the axons that are dying, or there they are here, nicely depicted and shown by a famous drawing of Bruce Trapp some 20-odd years ago. But what he did is he got people to actually count these axonal boutons indicative of axonal transections. Where were they occurring? Are they in the chronic areas over here, or are they in the most active type of MS plaques that one sees early on? And you can see that the data here strongly show that this is an active process that occurs very early on, usually in conjunction with inflammatory events, which are also seen in the chronic active type of lesions. But when you get into normal appearing white matter or chronic active lesions later on, you tend not to see so many axonal transections. So these are, a lot of them are occurring right up front, early in the course of disease. And this was eloquently shown by Tanya Kuhlman some many years ago, where she looked at the more or less tombstone marking of a dead neuron, which starts to express the amyloid precursor protein, shown here as pink. And in an area of remyelination, also where you can see the pink. And the points here are that the most of the APP staining were happening fairly early. These are patients at various epochs of their disease. Number one, it's they've only had MS for about a year, 1 to 5 years. These are actual brains that were looked at, and the longer duration, more than 10 years. Where did we see all these APP expressing neurons? In these very early years of the patient. Also, the biggest chance for a remyelinating plaque was also when they saw these APP staining neurons. We know that these stainings only last for about 30 days. And it's usually a marker of acute axonal damage. So this is something that is occurring early on, but it's only the so-called straw that broke the camel's back that starts to show up once the patient's exceeded that magical threshold where the axonal loss starts to manifest as clinical progression of disease. The MRI has shown us very early on that there are changes that occur, very much detecting the axonal damage in even the normal appearing white matter. And here, all you need to know about the MR spectroscopy is that the NAA peak, representative of an intact neuron, is much lower than compared to an area where there's no demyelinating plaque, as shown over here in this area here. The NAA to creatine ratio is much higher than it is over here, and the NAA to creatine ratio is here. And just to point out that NAA is a marker of neurons and axons. The neurofilament light chain has really changed our ability to look at disease that is occurring in the absence of any perceived activity from the patient. There's no other source of neurofilament light chain than the actual axonal breakage and the release of these neurofilaments that can be measured in the CSF or the blood, and obviously much easier to measure in the CSF, but we now have techniques that can pick up even picograms of neurofilament in the blood. So these are a marker of kind of like real-time axonal loss, although how long it takes for the neurofilament to leach out of the CSF into the blood is variable in most people. So interestingly enough, if one applies this to our understanding of MS in this nice little diagram that I've been referring to, if we look at this period of time in the RIS stage, this is before patients have ever clinically demonstrated that they had MS. We know that even at this stage, there's evidence of demyelination that was picked up on the MRI. But what about this axonal breakage that I've drawn this line all the way to the corner of this graph? Is there any evidence for that? And now it appears that there is, because an interesting study that was done in the U.S. Armed Forces, where they took patients and followed these soldiers over many, many years, they went back at the patients who actually had developed multiple sclerosis some years after joining the Army, and they all left them. When they come into the Army, they have to have a blood test. And so that blood test was then looked at, and they found that in the cases, already these patients, 6 years by before the first MS symptom was even seen, or even 1 year before the symptoms were ever noted. In this period of time, the neurofilament level was elevated. So axonal loss was occurring sometime before even the first clinical attack. Therefore, the inflammatory events that were picked up on the MRI are probably contributing to that axonal loss. We also know that the MRI, in picking up all that disease that was, say, silent before the patients first presented, have a very strong predictive value of how those patients are going to do and whether they'll progress or not. And this is very recent data from the Queen Square group, who have followed this first event MS population, the CIS population, 178 of those patients recruited within the first 3 months of their disease. And they looked at not only the amount of disease that they had early on, but as I was suggesting at the beginning, where those lesions occur tend to dictate the highest or lowest risk of progression, in this case, after about 15 years. So, baseline gadolinium-enhancing lesions, those are the inflammatory lesions that are seen at baseline, 3 times more likely to present with secondary progressive MS 15 years later. So those highly inflammatory events are very strongly predictive. Presence of spinal cord lesions, 4.7 times more likely to get SPMS. So inflammatory lesions in certain locations, very much calling the shot for long-term prognosis. Early focal inflammatory disease and spinal cord lesions were the biggest predictors of long-term outcomes in this particular study from the Queen Square group. We also know, when we try to tie together not only the MRI, but now tying it in with the neurofilament light measurements. So these are 2 markers of very early inflammatory events and axonal loss that one can measure by the amount of neurofilament that is leached out and measured in the serum. So you can see that if you look at the brain lesion load, if you presented with more than 9 T2 lesions, you also had the greatest amount of neurofilament. So this level is much higher in these patients. This reflects damage everywhere. Even though the MRI lesions may only be looked at in the brain, the NFL is picking up the damage wherever it is occurring, could be within the brain or spinal cord. So this correlates with GAD lesions. It involves both brain and spinal cord lesions in these patients. We have seen that the patients that have the biggest ability to heal in our bone marrow transplant studies were also the ones who showed the greatest amount of inflammation. So the enhancing lesions that also increased their MTR, a measure of complexity of intact myelin, those that had better remyelination early on in the disease were the ones who showed the greatest benefit by actually reducing their EDSS. So it can be done by controlling inflammation. We also know that the effect on relapses and inflammation may not just come up tomorrow, but there's this lag that we tend to see over time. And there's very recent data that was using mathematical models of saying if you checked inflammation today, when would you look to see if it's affecting at all progression? And the answer is it could be anywhere from months to years, depending on, these are the different drugs and their effects on the disease as we know it. With natalizumab having one of the greatest effects, you would probably tend to see the effect on progression now, but still only about a year later. So it really poses a problem for us to try to see if we're affecting progression by changing inflammation. When would we look? And that is key here. We also know that treatment versus no treatment makes a huge difference. It doesn't matter whether it's glutarin or fingolimod. These are all just different therapies. But the natalizumab and alemtuzumab being higher efficacy therapies, these are therapies that are much more dramatic at controlling relapses early on. They make a huge difference, as you can see here, in delaying, in this case, the conversion to secondary progressive MS. So you're altering progression by actually stopping these inflammatory relapsing types of events. Well, nothing stops it more than actually wiping out the entire immune system, as we've done in the Canadian bone marrow transplant studies. You can see here the number of GAD lesions before, the number of T2 lesions before, and afterwards, nada. going out to now we actually have 20 years. Here are the relapses that occurred in this group before. Here are the relapses that occur afterwards. Nobody had a relapse. It's important to see that that effect on these patients, here's that lag time that I was showing you. We wiped out all the relapses in these patients, but when did we start to see the stoppage of progression? Only after the first year. And then afterwards, there was no more progression in these patients going out almost 20 years. So in conclusion, this is an inflammatory condition, MS, that inflammatory events lead to axonal damage that eventually surpasses these compensatory or regenerative repair type mechanisms that patients have. And it's only when they surpass that that you start to see the progressive nature. That if we can stop these inflammatory events, you can actually stop or slow progression considerably. And when we think about primary progressive MS, that's really just the same thing. But early on, their inflammatory events were much more silent, and it would be great to be able to pick up some of those patients and intercede with some form of therapy that would stop that. So I rest my case, and I thank you very much for your attention.